Hello, everyone, and welcome to the Natus Neurotraining Academy webinar presentation today. I'm Dr. George Grudziak, Senior Global Medical Education Manager, Neuropathways, and I'll be your moderator for today. Our Neurotraining Academy platform provides you, our membership, with direct access to the latest educational content in neurodiagnostics, neurocritical care, and neurosurgery, all in one comprehensive location. So please visit our website regularly for upcoming events. Our presentation is entitled Clinical Neurophysiological Assessment of Motor Neuron Disease, a Practical Approach, featuring Dr. Paul Barkhaus. Dr. Barkhaus is a professor of neurology and physical medicine and rehabilitation and founder and director of the ALS program, as well as the director of the Neuromuscular Diseases program at the Medical College of Wisconsin. Dr. Barkhaus completed his medical education and training at Wayne State University in Detroit, followed by a fellowship in EMG at the University of Minnesota under Dr. William Kennedy, and additional training in quantitative EMG in Uppsala, Sweden with Dr. Eric Stahlberg, and Duke University with Dr. Donald Sanders. Also, Dr. Barkhaus began a productive collaboration in EMG research with Dr. Sanjeev Nandedkar, who at the time was a research engineer in the Duke EMG laboratory, and currently is a senior consultant here at Natus Medical. I might also add that Dr. Nandedkar is also in our audience today. Both Drs. Barkhaus and Nandedkar have been collaborators since 1986 on multiple research and educational projects. Additionally, Dr. Barkhaus has authored or co-authored 65 peer-reviewed publications and 40 peer-reviewed books, chapters, and reviews. He received the Distinguished Researcher Award from the American Association of Neuromuscular and Electrodiagnostic Medicine in 2015. So at this time, it is my great pleasure to turn the meeting over to Dr. Paul Barkhaus. Dr. Barkhaus, please, the audience is yours.
Thank you, George. And thanks also to Natus. I'm going to take off my video here and start our slides, which hopefully everyone can see. Thanks also again to Natus for the invitation, and I want to point out that they also have kindly agreed to donate this honorarium for me to the ALS Association, because it is because every waveform you're going to see in this talk was basically the result of their faith and confidence in us in our efforts in researching this terrible disease. So quickly, a picture of our campus here in Milwaukee, and a good day to you all, wherever you are. It's a chilly spring morning here. The medical college is here, and our affiliate institutions are the Children's Hospital and Frederick Hospital, where our ALS clinic is located. There is also an ALS clinic at our other affiliate institution, the Veterans Hospital, located about 6 kilometers east of us. Hopefully, I'm going to advance here. There we go. And again, most of the following in this presentation is copyrighted, so we appreciate no photography or video recording, but you're more than welcome to take copies whatever way you like of the references at the end here, and I'll let you know when that occurs. So George, we have our first poll question, please.
Yes, we do. So this poll questions, again, we like to see who our audience is today. What is your current level of patient care? Are you a physician, a researcher, a technologist, a practice, or a department manager, director, or an other type of professional today? So I will launch the poll, and we'll see what our audience is today. Great. I will close the poll, and I will share the results. The results are 52% physician, 37% technologist, and following that are researcher 8%, practice, department manager, director 5%, and other 4%. Wow, Dr. Barkhaus, great audience today. Thank you, audience. I will hide the poll, and we can continue, Dr. Barkhaus.
Okay, well, we have a lot of material to cover today. Hopefully we'll be able to manage it. So first question is, what is ALS? I think we haven't got a final answer on that, but what's agreed upon to date is that it's a disorder of the upper and lower motor neurons. It's typically focal weakness onset, but may have symmetric weakness onset. So it's quite variable, as well as in its progression. Spontaneous remissions are rare, but there are periods of, if you will, a plateau that's quite common. It's ascertained on clinical exam plus EMG, which is what we're talking about today, that reflects the lower motor neuron component. There's very minimal research as far as the clinical electrophysiology of the upper motor neuron component. And it's often obscured by the lower motor neuron component, which makes it tricky. So in summary, the diagnostic criteria, which we're not going to focus on, but just say briefly that it's become more, if you want, liberal, both clinically and electrodiagnostically, starting from the original Ellis-Scorial criteria in the late 1990s to the Awaji criteria that basically added fasciculation potentials for active denervation in around 2009, if I recall. And now the more recent Gold Coast criteria that can be seen in the reference by Scheffner et al. So you can kind of think of it as about every 10 years, there's a reshaping of the consensus criteria. So how does ALS present? Well, I thought what we could do is just look at a sort of fictitious but typical case history, and you can read this faster than I can, but we'll just say that in summary, this is a previously well person, and often these patients are reporting themselves as being very well, and they are in good health, suddenly experiencing painless progressive weakness without sensory loss. And in this case, it began in the left arm with progression to the bulbar region with his chewing and swallowing, and somewhat in the gait with his feeling his gait's a little off, but thought it's because of his left arm problems, which is often the case how patients attribute their problems. Now, I like to structure my clinical exams as if I'm looking at the patient in table form for illustration, and I want to just say that for our purposes here in the talk, whether it's EMG data, I'm not trying to deceive you. I'm just putting the abnormal ones in the orange boxes here so you can clearly see the abnormality. So he has basically a little weakness in the right shoulder abductor and greater in the left, a little weakness in the other external rotator and elbow flexors, wrist flexors, finger flexors, finger extensors, and in the abductor digiti quinti in the hand, which is supplied by the ulnar nerve. And notice here at the abductor pollicis brevis, it's considerably weaker, and it's a little weak on the right. Now, because of this being stronger on the medial side and weaker in the lateral part of the hand, that is in the thenar group versus hypothenar, this is referred to as the split hand phenomenon or lateral hand. Some investigators place more on this than others. I find it useful if it's there, but it doesn't change my opinions clinically if it's not. It's interesting to look for. And in this case, he's got a little bit of weakness in the hip flexors, which is quite typical. And we see fasciculations diffusely, wasting in the left thenar, not surprising with this level of weakness and the tone being increased. The myotatic stretch reflexes are increased, the jaw, and basically more on the left than the right. Some stiffness in the leg with circumduction, upgoing toe or Babinski sign on the left. So we have another poll question, George, please.
Sure, we have poll question, clinical question. With respect to electrodiagnostic criteria, which was the most recent change proposed in the Gold Coast criteria update, Scheffner et al. 2020? Was it A, fasciculation potentials can be used as evidence for active denervation? B, weakness and wasting in 3 limbs on clinical exam and on EMG? Positive sharp waves can be used as evidence for active denervation. Or D, lower motor neuron dysfunction in two limbs, clinical or on EMG exam. I will launch the poll for your choice. And okay, we have a good response. I'm going to close the poll. I'm going to share the results. So our audience thinks it's A, Dr. Barkhaus, and B, and D rather, A and B. Most of the audience thought it was A and D. Comments, please.
All right, well, let's move on. And it's actually lower motor neuron dysfunction in two limbs, clinical or on EMG. And let's talk about this more in a moment as we move along on the slides. So we look at a case summary here of onset in the left arm. In the examination of presentation, you can see upper motor neuron would appear to be present in the bulbar, cervical, and lumbosacral regions on the left, and lower motor neuron in the cervical and lumbosacral regions, again, bilaterally in the cervical, more on the left, and minimally on the left. So the criteria would differ depending on which set you use. And again, these are coming up about every 10 years in revision. So the Ellis-Gorial wants definite in 3 limbs to 2 limbs probable to possible in 1. The Awaji criteria basically allowed fasciculation potentials to count as fibrillation potentials as evidence of active denervation. And the Gold Coast criteria is more extensive than what I show here, but basically the important thing was chronic reinnervation, meaning enlarged MUPs. Instability was not a criteria, and ongoing denervation using fibrillation or fasciculation potentials, and lower motor neuron in 2 limbs or upper and lower in 1. And the recent article by Dr. Scheffner et al. Nicely summarizes that. Should we proceed with an electrodiagnostic study? And I think this slide's important. And the answer is yes, if you're comfortable performing a complete study and prepared to deal with the results. If not, or if the patient is likely going to be referred to an academic center, consider stopping here. There is no dishonor in this because patients are quite aware and also may already sense they may have a bad disease. And if you do the study and just simply say, I'll write the report, goodbye, that's not going to satisfy them too much. On the other hand, if it's not your patient and you're simply doing the study, then you're in an uncomfortable position. So if you have a patient where this is a possible scenario, hopefully you know your referring physician and you can work out some mechanism that a proper discussion of the results can be done in a very timely way. And I think this is often overlooked, but that's my little advertisement, if you will, for being careful about doing these studies, because you may be technically excellent, but not prepared to deal with the results in the immediate way to help the patient deal with it. So what electrodiagnostic information do we want to know and why? Is the regional distribution on EMG greater than that seen clinically, going rostral to caudal? We're going to obviously want to exclude mimics, that is multifocal motor neuropathy, sporadic IBM, myasthenia is the main ones we tend to think of, and documenting presence of neurogenic disease, active versus chronic. So the clinical neurophysiological evaluation of suspected ALS motor neuron disease, we do nerve conductions and sensory, of course, and these might be abnormal in about 10%. They may have unexplained sensory complaints or abnormal sensory potentials. That is over and above not being diabetic, which of course is common in many populations. Motor conductions, we want to make sure there's no partial conduction blocks or abnormal temporal dispersion. And in our lab, we like to do the upper extremity nerves to the axilla. Conduction velocity, again, these are criteria from the CIDP studies, and I don't want to spend much time here. Most of you are familiar with these. I just bring them up for completeness. One caveat is that in our work, we are very cautious about accepting any CMAP that's less than 500 microvolts, and do not use these in motor unit number estimate studies, because these can easily be far field potentials. F waves, I have no opinion on. They certainly can be done. We typically don't do them. And repetitive motor nerve stimulation, I tend not to do, but I do see some people include this, and we can talk about this in a moment. So let's look at the sensory conductions, and in this case, our table shows that this is not quite abnormal, but it's certainly kind of borderline. So I would consider this to be of uncertain significance. The caveats here are that you should average these sensory potentials until smooth, and reproduce a second run like somatosensory evoked potentials in very low snaps to ensure their reproducibility. The superficial perineal is probably the most challenging to record, as there are variations in the course of the nerve. Now, the motor conductions, again, we see some abnormality here, and not surprising. The left APB thenar eminence muscle was weak, so it's not surprising the CMAPs are low. And in contrast, the ulnar CMAPs are normal amplitude, again reflecting this split hand phenomenon when you see it. So it's a matter of being aware of it and looking for it. The tibial drops not uncommonly to about half between distal and proximal, and this is not abnormal as such. I'm highlighting it just to make people aware of it. Most people are, and the reason for this we did in an investigation some years ago with Dr. Nandedkar. So the needle exam, the old thinking is find big MUPs, fibs, and fascics. I think the new thinking should be, what am I looking for and where can I find it? So a strategy, meaning where is it abnormal? What muscles are going to tell me things? And then can I extract more information than the traditional approach? And the short answer is yes. So this seems like a busy slide, but I just want to point out a few things. The highlighted orange here all shows abnormal muscles that qualify as abnormal, meaning showing active denervation, whether fasciculations or fibrillations, and changes in the motor unit potentials, meaning the durations are increased and recruitment patterns are down, very obvious. Here, the left biceps is not going to or will qualify that previously would not have before Awaji, but now we can add this as evidence of active denervation, so this can be abnormal. The left triceps and gastrocnemius show fasciculation potentials, but the motor unit potentials are normal, so they do not count. And notice that the sternocleidomastoid shows a pattern of fasciculation potentials and a little bit of enlargement in the motor unit potential. So this does qualify as an abnormal muscle that previously, before Awaji, would not have. And we tend to like this muscle, and this was demonstrated by Lee et al. In a study of EMG and the sternocleidomastoid in ALS, as opposed to the tongue, which can be done certainly, but this is a much easier and more comfortable muscle. Quickly, one can see occasional other phenomena like myochamic discharges and complex repetitive discharges. These are of uncertain significance. They certainly suggest abnormality, but do not count as toward defining motor neuron disease. So this again is a summary slide of the previous slide, and I'm going to move on because you can look at this at your leisure if you choose to look at the recording again to just highlight the abnormalities. So now let's do the case summary again with adding a column here, the EMG results, and as you can see, we can add yes, yes, yes for evidence of lower motor neuron. So this more than qualifies as ALS, whether you use the original Ellis-Scorial criteria or the newer Gold Coast criteria. So what now? Discussion of results with a patient. The breaking the news, or we call it BTN session, can be quite difficult and stressful for both you and the patient. This is not the patient you want to be talking to when you have 2 more studies to do in the lab. So this is where, again, I stress setting things up so that you can do the study and have time to discuss with the patient as would be appropriate for the situation, and that will be up to you to decide. So what is the significance of these findings and how are these found? So we'll kind of deconstruct things and go through them in some detail. So a few quick points on sensory conductions, because we could spend an hour talking about these alone. This is a slide that we helped work with in the AANEM guidelines that were published in Muscle and Nerve in October of 2020. There was a previous guidelines, but I would emphasize this one in October to refer to. Notice that you can change the amplitude of the snap quite easily. So in this case, we want this one as being showing the true amplitude of 8.4 microvolts, not artificially shorter at 3.7 or artificially larger at 13.9. So be honest about it, so you record proper sensory potentials. The motor conductions and the CMAP. So what is the CMAP? It's really not an action potential, and I've had discussions with this with different colleagues. Some call it maybe more appropriately an M wave. We could at least call it a CMP. I'm going to call it a CMAP for our talk, but I'm going to keep the letter A in red as much as possible, and I already forgot to put a red one there to remind us that the action shouldn't be there. So it's a summation of the surface recorded motor unit potentials when a motor nerve is stimulated. When you slowly increase the stimulus to a motor nerve and an affected muscle in motor neuron disease, you do see small increments of a few milliamps in the normal, but in this case, you expect to see large discrete incremental jumps, which should tip you off that you may be dealing with motor neuron disease, whether the CMAP is normal or reduced. And let's see an example of this. So here is a patient with ALS, and this is the hypothenar or abductor digitiquinti. And notice with stimulation from the liminal stimulus at baseline, where there's nothing recorded, we get a discrete first response. And again, these are repeated stimuli showing this is basically the same surface recorded motor unit potential. Then when we increase this slightly, we jump. And notice we see these gaps. This is very suggestive of reinnervation. Now, it's not specific to motor neuron disease. Of course, you could see this in any other motor neuron disease, or frankly, a case of radiculopathy or polyneuropathy. But it's very prominent when you see this in motor neuron disease. And notice up here, then when we get higher and higher, it's harder to tell these apart. But at the lower levels is when you see these jumps. And notice out here we have an F wave, but the F wave is a large amplitude, which should be a tip-off that this is a reinnervated or a CMAP composed of reinnervated motor units with a larger innervation ratio, and also that these are repeaters. This is the same F wave repeating itself. We can't tell based on this display where this F wave is coming from. Is it from this first one, or is it from higher up here? We can't really tell. Motor conduction studies. The key waveform is the CMAP, of course, and it only records to a depth of about 15 to maybe 20 millimeters into the muscle. So no matter what muscle you record, whether a large one or small one, you're recording from the most superficial motor units. And the differential diagnosis, of course, we want to exclude multifocal motor neuropathy, because the patients or referring doctors will ask us about that. And by doing this, we can tell them with confidence that no, we did not find any evidence for it. And then in chronic reinnervation, the SMUPs are increased in amplitude and decreased in number. And we see this reflected in the F waves as well. If the CMAP amplitude, negative amplitude appears reduced, suggesting conduction block, then or partial conduction block, then use the negative CMAP area as a qualitative measure to see if this is true conduction block versus abnormal temporal dispersion. And a true CMAP should show an appropriate twitch of the muscle when stimulated. If you're seeing a response and there's no motion of the muscle, be very suspicious. And again, as I said before, very low ones we don't really even report. And we discussed this in our paper with Dr. Carvalho back in 2018. Is there a role for repetitive motor nerve stimulation? My opinion's no. It would be uncommon to confuse the patient's history and exam with myasthenia, although in mild cases, certainly it's possible. If Lambert-Eaton myasthenic syndrome is suspected, then a 10-second exercise test can quickly be done. It's uncomfortable and adds cost. So if you think it really is needed, then I would move to the needle exam first, because if it shows extensive reinnervation changes, then frankly, I don't think there's any reason to go and do repetitive motor nerve stimulation. It wouldn't make any sense. And of course, the basic concentric, or if you use monopolar needle exam, needle electrode for your examination, is unremarkable. Be sure to assess MUP stability, because if the units are normal and there is instability found, then you would suspect a disorder of neuromuscular transmission. And this is a very sensitive marker for this, as in what we call jitter, of course, and what used to be single fiber studies, but now we call jitter studies because we're not using a true single fiber electrode. Now, here's a very interesting picture, screenshot we took many years ago from a single motor unit we followed in a slowly progressive patient over the course of a year. So I don't think you'll ever see this. This is repetitive motor nerve stimulation of a single motor unit. And the amplitude of this SMUP is huge. It's 2 millivolts. The decrement is 8.1%. Now, this phenomenon was realized many years ago by Forbes Norris, an early worker in ALS, and this inspired him to try mestodon or pyridostigmine in ALS patients to see if that would help their weakness. And of course, unfortunately, it did not, but it was a very good idea at the time. Nerve conduction studies and their role in assessment of motor neuron disease. So it's basically to determine if there's any associated polyneuropathy or focal neuropathy. We certainly see these in these patients. Common things are common. Again, excluding any process suggesting demyelination, any process that would suggest a junctional disorder, although I would advocate the needle exam as being better at this. And then if there's a pattern of proximal bulbar weakness associated with absent sensory responses suggesting Kennedy's disease. Now, the needle electrode examination, we break down, of course, traditionally insertion activity. It's, of course, nonspecific and need only be noted as normal, increased, or decreased. Spontaneous activity. With fibrillation potentials, which also can be in the form of positive sharp wave fibrillation potentials, fasciculation potentials, and then these nonspecific iterative discharges like CRDs, myotonic discharges, or group discharges like myochymic discharges. And then the motor unit potentials showing changes in amplitude, area, duration, and complexity, meaning increased phases and turns. MUP stability, which we'll talk about a little later, and recruitment, which we will not discuss because of constraints of time. Well, George, we're now to another poll question.
Yes, we are. In this poll question, which of the following is not true of positive sharp wave? A, tend to have larger amplitude with longer chronicity of the condition. B, can evolve from a triphasic fibrillation potential. C, can be better seen at high pass filtering if small in amplitude. Or D, they may simply be a monophasic variation of a fibrillation potential. I will launch it for the audience to consider. And let's see, 2 more seconds. Okay, great. I will close the poll. I will share the results. So, Dr. Barkhaus, our audience thinks it's A, tend to have larger amplitude with longer chronicity of the condition. Comment, please.
All right. And you are correct. It should be smaller amplitude, and we'll discuss the others in a few moments. So fibrillation potential, just very briefly, we have usually a pacemaker or a pacemaker, typically at the area of the denervation of the denervated end plate. And we're recording it often away from that area, so it has a triphasic appearance because the electrode senses the incoming positive field generated. This is all based on the work many years ago by Laurent Deneau, and then the depolarization or negative going phase when it's under the electrode, and the basically return to baseline with this slight positive wave here, so making our triphasic wave. Now, positive sharp waves are non-specific. They're only a fibrillation potential when they behave like a fibrillation potential based on their rhythm and discharge, etc. And we tend to record these when the electrode is near a non-functional part of the membrane and the pacemaker is discharging here, and with only sensing this incoming wave of positivity, and there is no depolarization because there's no viable membrane here. And these can have various possible etiologies. Now, can a fibrillation potential, so-called, become a positive sharp wave? And the answer is yes. And we showed this many years ago in a paper with our colleagues. And let me show you this. And you should be able to have some audio. And we had other examples too, but notice, and the needle position is good because this is the same here when this flipped back and forth, but it briefly went into becoming a positive sharp wave. And again, that we also see what we call, used to call nachos, not the snack, but because the positive sharp wave looked like a W, would come up and then go back down and back up to baseline. I never could quite figure out what those were. And then with doing extensive recordings, we found that this was basically a cannula recorded, presumably, fibrillation potential that looked like a positive sharp wave with that little notch in the bottom. So these are all just variations on a theme here. So further points on fibrillation potentials, a little trick I found over the years from my doing single fiber EMG. The muscle fiber action potential reflects the muscle fiber's diameter in many cases. Therefore, a newly denervated muscle fiber will have a larger amplitude than one that's been denervated for some time, i.e. many weeks, and thus atrophic. So in case, or if we can't really tell with confidence these smaller amplitude fibrillation potentials, I like to compare it to a microscope. And here we have a low power objective and a high power objective. So if we can change it and sweep and bring the high power down here, we can reduce the recording area of the electrode, and it doesn't matter monopolar or concentric here, to a smaller defined area so we see what's going on at the tip here. So we give up area that we're recording from, but we're gaining the ability to see the detail of the microenvironment right at the electrode tip. And this is done by using trigger delay and increasing the get my pointer back here, the low frequency filter from 5 hertz to 10 kilohertz. Here's the 5 hertz to 10 kilohertz range, and by changing the filter, we substantially reduce it to our advantage. But you have to remember to switch it back when you're going to look at conventional assessment of MUPS. So fasciculations, the bottom line is everybody has them. It's the spontaneous discharge of a single motor unit. They're painless, usually imperceptible in normals, and of course, seen better in superficial motor units in people, especially in motor neuron disease patients. And when they're perceptible in normals, you kind of suspect aggravating factors as listed here: fatigue, stress, dehydration, etc. Continuing on, there's no definitive way to separate benign from so-called malignant fasciculations, and we don't like to use those terms at all. The fasciculation potentials are the electrical analog of fasciculations, first basically described by Denny Brown many years ago. I have a funny story about that, but time doesn't permit to talk about that. These can arise anywhere from the soma, the motor neuron, to the nerve terminal. The distal origins of fasciculation potentials in ALS were demonstrated by Francis Forster when he was at the University of Wisconsin at Madison, just west of us, about 100 kilometers in 1946. It's a very interesting paper. I can't talk about it now because of time constraints. The reason that they're better seen in motor neuron disease is because we have enlarged motor units. The innervation ratio is increased, so it's quite easy to see these twitches in patients. And then I would just point out these two recent studies, literally within the last couple of months, showing that we may need to pay more attention to fasciculation potentials than we previously had, including some of their behavior, which I'm going to show you in a moment. So how to find these? Well, I like to compare it to fishing. If you're there looking, you want to hold your electrode or pole steady in place, and a minute is sufficient time to say that no fasciculation potentials are recordable at that particular site, and you can move on and so-called fish at another site. And this was nicely discussed by Dr. Mills in his paper, and later by Dr. Zhu that I collaborated on in 2012 using high-density surface EMG. And sometimes we think that if we activate the patient, have them push against us hard with a particular muscle, that might provoke these to come out quicker, but I'm not sure that's correct. I used to think so, but now I'm beginning to think I'm just, it's a fiction that I believe in. They're usually slow firing and irregular. They may certainly repeat, and it's easier to use record them using a trigger delay line. I emphasize this is a terrific tool to use on your system. And I'm going to show you a recording, and pay attention to the dashed line up here, which appears later in the recording, so you can see how nicely we can collect these and examine them to tell if they're repeaters or non-repeaters. Now we're in kind of a standard sweep mode. Now we have the trigger delay on, and we set it arbitrarily. You can put it at 100 microvolts. You can make it lower if your baseline is very stable to around 50. Remember, you can have distant fasciculation potentials that are just a slight distortion in the baseline, or may appear as a large positive sharp wave. And here we have one that repeats. It's unstable, not surprisingly. Here's another one that's repeated, and that's pretty cleanly superimposing. Now, can a fasciculation potential trigger an F wave? And the answer is we think so. Interesting concept. So a discharge down here would go antidromically up, much like when you would stimulate a motor nerve, doing motor nerve conductions to get F waves, except it would be more distal, presumably, and then come back down. And here we have intervals that very closely match what we'd expect to see the distance for an F wave in the lower extremity. This would be here 54 milliseconds and 46 here. And again, the fasciculation potential mystery goes on. Here, this is evolving into a group discharge. Should we call it a myochemic discharge? So here's one sweep, here's another. It suddenly starts to get a friend here, and then all of a sudden there's multiple. But let's look at it as a video. Why not? And also, can you see the double or extra discharge? Everybody has a favorite discharge, I think, fasciculation, fibrillation. Mine are double discharges that I learned from Professor Stahlberg, and that's discussed in his book here, if you're not familiar with them. I think they're kind of fun. And that's that little second potential you see occurring there. You hear it as like a split heart sound. So this is basically fasciculation potentials on steroids. There's the extra discharge or double discharge. There it is again. You can see these in normals. They're non-specific. It's just important that you recognize them for what they are. This goes to the more recent papers on fasciculation potentials. Here's a patient we had with the fastest progressing ALS I'd ever seen. It was literally months. And I'm going to show you what his arm looked like in a video clinically, and then a recording of what we recorded as his fasciculation potentials. And again, I emphasize this recording was made with a patient completely at rest. So they fulfill criteria as fasciculation potentials. So let's watch his arm here, and it's literally shaking. And as you watch that, I'm going to start this one. Now here, the clever part is, and I owe this to Dr. Nadadkar, we couldn't analyze them in the traditional way of like trigger delay, so we used the multi-motor unit analysis program to record these and analyze them, and here it captured and sorted out 4 distinct fasciculation potentials, which are in essence spontaneous motor unit potentials. And they're not very enlarged, which goes along with his rapid progressive ALS. So this is a very nice demonstration and brings us back to the profuse fasciculation potentials and rapid progressive ALS that was discussed recently by Avedon and colleagues. All right. Concentric needle motor unit potential and motor neuron disease concepts. It's a selective recording of the muscle fibers of a motor unit. It does not record from the whole motor unit territory, as you know. So it's sensitive in finding early focused remodeling in the motor unit. So it's useful for diagnosis, but as it's so selective, it's not useful for recording or monitoring disease progression. A repeat study, I would say, is only indicated or useful when the motor neuron disease is suspected and the initial study is within normal limits or non-specific or very minimal findings. And here again, you can see that if we have the whole motor unit territory, and again, this is a very schematic cartoon, we have these different potentials, and number 3 is the one closest to the electrode and therefore contributes most to the amplitude feature of the motor unit potential. There are some people that allege that there's 15 muscle fibers that contribute to the duration, but that I don't believe is quite correct based on simulation studies. But I do think it's safe to say that the main spike feature here, from here to here, is reflective of about 15 fibers in the normal, but then when remodeling occurs in motor neuron disease, then of course there may be many more contributing, and thus you see the large amplitudes and durations. All right, George, I think we're to our last question here, please.
Yes, this is the last poll question. Which of the following statements is true? Concentric needle EMG is useful in tracking reinnervation. About 35% of the motor neurons are needed for an MRC grade of 3. In chronic denervation, reinnervation, weakness is noted at about 35% of motor neuron loss. MUP instability is required as part of the Gold Coast criteria. All right, I will launch the poll for our audience. And let's see what our audience thinks on this last poll question. Okay, great. I'm going to close the poll. I'm going to share the results. Wow, so our audience thinks it's concentric needle EMG is useful in tracking reinnervation. Seems to be the consensus here, with number 2 on the chronic denervation, reinnervation weakness.
All right, well, this is my answer. Maybe I'm going to fail. I'm going to say that chronic denervation, reinnervation weakness is noted at about 35% of motor neuron loss. As I just said before, it's a selective recording, so it's not useful in tracking reinnervation in the sense of +2 duration versus +3 duration. Those are sort of implied qualitative statements about the packing of the muscle fibers as the reinnervation occurs, and it's going to be highly dependent on the location of your needle electrode. So I'm going to answer this more as we move along. So here we have, let me see if I can, dare I back it up here? Okay, well, it was only one slide. This was the slide I showed right after the poll. This shows the big range of 4 when we look at force in newtons. And not surprising, anyone doing clinical neurology and EMG knows this. And their point was it takes about 3% of force in newtons to generate grade 3. So we have this huge range here, and how we start to look at motor neuron loss and what the correlates are. And it's right about here we start to see clinical weakness. So in this schematic here, we have 100% and 0% of our motor neurons on this side. And along here is the duration of disease, whatever it might be, and onset, and then complete paralysis. So as we decline and hit about 30%, we get onset of clinical weakness. At about 30% loss of motor neurons, assuming compensatory reinnervation is occurring down here. But this mechanism is only so good until it starts to fail, and then it hits complete paralysis. And we see this in ALS in all of the muscles all of the time. And the key question is how successful and why is it successful or not successful in motor neuron disease. So as we all know, we have like 3 motor units here, as I've shown in the schematic, 1, 2, 3, and let's say 2 dies, and the fibers of 2 that were in the territory of 1 can be innervated by number 1, but some, of course, may not achieve reinnervation by 1 or perhaps another motor unit. These are many, many motor units overlapping in territory, and number 3 as well. Again, a 2 that never came back getting innervated, but 3 picked up 3 of them over here. And of course, these are still out. And whoop, nuts, see if I can get this to work now. Okay, we're back to that. Oh, here we are. And we have normal size motor unit potential, but then when the innervation ratio starts to increase from 1 to 500, for instance, in the biceps, to 1 to 600, 700, 800, 1,000, then we see this increase in size, especially we see it in the main spike. And that's what we see when we look at the histology and you see the fiber type grouping. This does not mean this is one single motor unit here. This is just simply reinnervation of a similar histochemical type of muscle fiber. All right, so let's look at a more conventional large amplitude MUP we see in chronic and typically slower progressors. And then let's look at a fast progressor, and this is going to sound a bit like a nascent motor unit, but it's not a nascent motor unit. It's one that's failing innervation. And you can hear the instability by that but it has that crackly, high-pitched sound that almost sounds, in a way, myopathic. But myopathies typically are not unstable. They may show a minimal amount of it, but not to this degree. And here is a screenshot of a rastered sweep here of some rapid progressive motor neuron disease, where you see the main one here, and it doesn't change too much. Over here, this last spike is the same, but this one occurs at a different, well, it's the same here, but not the same here. So that's the trick. And by rastering these with trigger delay, you can easily see the changes. It's like a chameleon. Every sweep, it's different as you watch it, and depending on the number of sweeps you choose to follow. But again, it could look a lot like a myopathy if I just showed this to you, but then showing a series of these occurring as they're activated and firing, you realize with this amount of instability, it's highly unlikely it's a myopathy. So assessing disease activity in motor neuron disease using concentric. So again, this is, we can qualitatively look at this as stability, and we can again use that analogy of our microscope going from the low power to the high power, bringing the high power down and focusing by reducing our territory of recording substantially in. So we're looking at the microenvironment of the motor unit, if you will, right around the tip of the electrode. And it's kind of a three-step process. We're changing the open bandwidth filters of 5 to 10 kilohertz or whatever you typically use in your lab, and run it up to 1 kilohertz. You don't change the upper part. And then we want to see this on free run first, then we want to use our trigger delay to time lock it and perhaps increase the sensitivity, because when you change the filter, you will lose amplitude. But then also we increase the sweep. Then you see that second spike that was hiding in here. You'd see it occasionally, and it becomes very obvious here. And this is reflecting instability in this motor unit potential. Now, if this was normal appearing, this would be typical of a neuromuscular junction disorder. If this was multiple spikes, as you saw in the last slide, then it would be fairly obvious that we would be suspecting a chronic reinnervation process. So an unstable MUP, let's look at this again to get a feel for this. Here it is on free run on the left, and you see rastered sweeps. And we're going to change the filter shortly. And trigger delay. And now you can see it very clearly, this instability. And we kind of also call this the poor person's single fiber EMG. Here, potential that may look stable at standard settings may be very unstable when you change the filters. If it's unstable at standard settings, then I don't think you really need to change the filters unless you're interested in looking at it further. But if it looks okay at standard settings, then you may wish to use that maneuver I just showed you previously. So MUP instability, if it doesn't count in the Gold Coast criteria, why discuss it? Well, I like to think about the future. Combined with signs of active denervation, instability is useful as a qualitative metric to differentiate an indolent chronic process from an aggressive active one. The caveat, there's always an element of sampling error, so you do have to, you can't just do one and say, oh, it's stable or unstable. If you study 2-3 MUPs and they're very unstable, then I think you have a good argument. And of course, correlating that with the progression of ALS itself, there are periods of apparent clinical stability, as nicely outlined by our friend Dr. Bedlack at Duke in his paper in 2016, which I'd recommend to you. So let's say that The last word on stability hasn't been said, and I think that it's very possible in the next 10 years when more people are comfortable with assessing it and using it, then it might be employed as a routine and incorporated into the assessment of motor neuron disease. And this I adopted from Professor Stolberg, which is a very nice way of thinking about things. Here we have fibrillations from none to major 4+, and stability to instability or unstable. And ALS would be up here. We tend to, of course, see active denervation, fibrillation potentials, and we see a lot of instability. Here it would be the normal state if you had a normal appearing motor unit potential and no fibrillations, and that's normal. But let's say you had an enlarged motor unit potential suggesting reinnervation and no fibrillations and stable, then that would be a process that's resolved. Say a person who had a radiculopathy operated on and there's no more active denervation, and over a number of months reinnervation is completed of the orphaned muscle fibers, and that would be down here. So putting it all together, at least with the gold criteria in red font, the MUPs, they want large amplitude, long duration. Complexity doesn't count. MUP stability is certainly, I think, worth looking at, but doesn't count. Fibrillation and potentials and fasciculation potentials, of course, do count, and other odds and ends phenomena, myokymia, myochemic discharges, I should say, and CRDs are not common, but sometimes we see them, especially more in the rapid progressors. So now back to monitoring. Monitoring in ALS in the last couple of minutes here that we want to talk about would be motor unit number estimation, which we've been interested in and done a lot of work with in the last few years. So the CMAP is the fundamental signal upon which all Muni techniques are based. That's the first thing you have to know. The commonest Muni technique used has been the incremental multi-point technique. I'm not going to have time to discuss that. I'm going to do more or dwell more on the Munich's technique that we developed. One problem is that the Muni has several drawbacks with the incremental stimulation method, which again, I don't have time to go into. It's limited to basically distal muscles. Other spin-off methods like spike trigger averaging we did for a while. F-wave statistical methods have not proven satisfactory for various reasons. And some years ago here in Milwaukee, Dr. Nandedkar and I started to work with our ALS patients and working out a new technique called Munich's. And Professor Stolberg has been inspiring us along as well and has participated in working out some of the quirks in this technique. It's still a process and evolution, but it's now thankfully being accepted as a biomarker in some drug trials. And there's a recent review on Muni by Dr. Carvalho I recommend to you, as well as a recent paper by Dr. Nandedkar a couple of years ago, kind of summarizing the technique of Munich's. So these are meant to be sort of gestalts because we don't have time to deconstruct it and show you the details, but if you just kind of understand the concept, hopefully you can go with the flow here. Here's our CMAP in a normal APB, and it's good amplitude. And then what we do is we measure the voluntary surface EMG activity using the same electrodes we use to record the CMAP. And again, we can't go into all the details, but what you see here is going from low activity surface EMG, barely active, going up to full activation, or what we would call an interference pattern, right? And we have an increasing surface signal here. And I know George is signaling me that time is short in a very diplomatic way. So let me move along and show you the CMAP in a ALS patient. And here you can see the regression line is shifted way over, and it's very low here. And it's no secret that you basically are seeing the same motor unit here firing simply faster as he makes a greater effort. And here's a bicep serial study from the first study to the second, and then this is shown again over here. So again, it's no mystery. You see a progression here from low activation to high, low activation, but much higher signal here with these surface MUPs to much larger here. Although they do summate, it's hard to tell them apart. And then you can just simply see we had a drop in the CMAP of 3.9 to 1.6, and we went from a Munix of 80 down to 25. And the Mu6, the size index, went from 49 microvolts up to 64. So when you think about it, the CMAP dropped by about half, roughly, and the Munix went from 80 way down to 25, so it was a greater loss. So we see more of a reflection in the disease in the Munix than just looking at the drop in the CMAP amplitude. And what does this show us here? Well, look here, what I said here with the reinnervation failing in the schematic, and we see this nicely demonstrated here. And the last couple of slides here, we have compound muscle action potential index, alternate way to track motor unit loss by just simply using the CMAP, and here we just add them up and we have a table. And again, you can see over time, we just have a simple drop in summating all the amplitudes, and this refers to this paper here that you can consult. And I will thank you for your attention and acknowledgments to my colleagues, mentors, Dr. Stolberg, of course, in Uppsala, and Sanjeev, and of course, many others, but predominantly them. And we say namaste to thanks also to our patients who gave of their time over the last 25 years to make this a success. And now you're welcome. I'm going to go slowly closing out here to show the references, so feel free to snap a picture. And the next, and these are going to be up anyhow, I guess, in the recording, so there's no pressure.
Yes.
And now that's the end, George, honestly, and here we are.
Yes, well, thank you very much for that impactful and information-packed presentation. Thank you so much. I think we have time for one question. There are other questions, but we will get them to you. We'll respond by email. So we have a question here. In the LS Corio criteria for ALS is only for a patient with clinical ALS, both lower and upper motor neuron disease, or is it used for lower motor neuron disease too?
I'm not sure I understand it. The
LS Corio criteria for ALS
right
is only for patients with clinical ALS, meaning both lower and upper motor neuron disease.
Right.
Or is it used for lower motor neuron disease too?
Well, no, it's just for ALS. For lower motor neuron disease like spinal muscular atrophy, if they're asking, no, we don't use that criteria, but they do incorporate EMG findings to supplement abnormalities to document lower motor neuron disease presence is the point, because people can be still clinically strong, as we said before, losing up to 30% of their motor neurons before they're clinically weak. So you could have a strong muscle and still find reinnervation and active denervation going on.
Mm-hmm. Okay, how about this one? So is it enough to diagnose ALS with EMG finding with ongoing denervation and reinnervation in two limbs without upper motor neuron affected clinically?
Yes, this reflects, and I would recommend you go back and read Dr. Scheffner and colleagues, their Gold Coast criteria. That's that reference I pointed out at the very beginning and is listed in the references. They break that down better. It's always hard to discuss these criteria, and that wasn't the main emphasis of this talk, so I don't want to mislead anyone. I think you need to go back and read those in detail. But yes, they're saying that it's enough to have 2 lower motor neuron findings in 2 limbs.
Okay, well, thank you very much.
I tend to be more conservative and play it safe.
Thank you
Fantastic.
very much.
That was wonderful, Paul. It was a delightful lecture, and we will try to get you the questions that we were not able to respond, but very nice summary of Munich's and the compound muscle action potential itself. It's always wonderful to hear from you about the CMAP and ALS and your patient management, etc. Thank you very much. Anything else, George, you want to say?
No, I think for now, I think there's 1 or 2 questions left, or a couple more. We can do that via email. But for now, we'll be closing our presentation with respect to time for our attendees, and of course, Dr. Barkhaus and you, Dr. Nandedkar. So on behalf of Natus Medical and our Neurotraining Academy, we extend our thanks to Dr. Barkhaus and of course, Dr. Nandedkar. And this will conclude our presentation for today. Thanks everyone for your participation, and we look forward to seeing you next time. Have a great day. Thank you.